Okay, I think most people have entered the room, so we'll get started. Well, there's a few latecomers. Good morning, good afternoon, or good evening, wherever you're joining us from. My name is Amy Savage, and many of you know me. I work in the Climate Change and Health Unit here at WHO headquarters in Geneva, and I'm very pleased to welcome you to another of our webinars in our Climate Change and Health technical series, technical webinar series. So today we'll be learning a little bit more about using quantitative approaches and modelling in a climate change and health vulnerability and adaptation assessment. But before we start, as always, just a little bit of housekeeping. So we have 2 sessions of each of the webinars to cover various time zones. We had one earlier this morning, Geneva time, and then this one here in the afternoon, our time. They generally cover the same content, but there is a difference in the country presentations. So if you're interested in seeing the country presentations from the morning session, they will be available as a recording on our website in a week or so. And here is the schedule of our upcoming webinars, which you're probably quite familiar with. You can see that we have a little bit of a summer break in August, and then we're back in September to introduce you to our upcoming guidance on integrating health in NDCs. And in this session, we do have simultaneous interpretation in French and Spanish. So please see the instructions on the slide and set up your interpretation now if you'll be using it. As with the other webinars, we've actually set this up as a meeting format rather than a webinar, just so that we can have a little bit more engagement and discussion, and particularly in the Q&A session later in the agenda. But there are quite a lot of people here, so I do ask you to please remember to just stay muted when you're not speaking, and feel free to use the chat and the Q&A functions, and we'll endeavour to respond during the session if the time permits, or afterwards as need be. As mentioned, the webinar is being recorded and it will be shared on the WHO website for those who couldn't make it. So here you can see the agenda for today. In a moment, we'll hear from Dr. Diarmid Campbell-Lendrum, who is the head of the Climate Change and Health Unit at WHO, for some opening remarks and really to set the foundation for the rest of the content for the webinar. Then we'll hear from Dr. Adugna Woyessa, who will provide an introduction to quantitative modelling in V&As. And after that, we'll have an opportunity to hear from some case studies. We have Professor Genito Maure from Mozambique and Dr. Peter Berry from Canada. And finally, we'll open it up for some discussion and Q&A. So with that, I'm really pleased to hand over to Dr. Diarmid Campbell-Lendrum.
Thanks so much, Amy, and thanks to everybody who's joined. What I hope you'll agree with me, I think it's been a very well-designed technical webinar series, and as you've just seen from the slides, is quite comprehensive, covers a lot of ground in terms of the various issues that we think people need to know about in terms of responding to the health impacts of climate change. So I'll just take about 10 minutes or so to provide a few introductory remarks and sort of put the work around quantitative assessments in vulnerability and adaptation assessments in context. So I'll just do the usual technical check that people can see my slides and you can still hear me.
Yes,
we're still okay. Great. Okay, so as those of you who have joined us for previous webinars may remember, we kicked off the series talking about vulnerability and adaptation assessments, because we think those are one of the foundational pieces to start responding to the health impacts of climate change. So we need to understand the problem. We need to understand the health risks that we have, which are already sensitive to weather and climate. And we need to understand how those are likely to change as climate change progresses. And so the slide that you can see now is perhaps familiar to some of you. It's the very systematic and logical process that we in partnership with others, including people like Peter Berry and who will be speaking later in this webinar, have defined, have described in order for countries or stakeholders to work through this assessment. And it goes from having a logical process to plan and deliver on the assessment in terms of setting up the right team, consulting with stakeholders, and so on. And then it takes you through a series of logical steps in terms of understanding what the current burden or the current health challenges that you have, which are likely to be affected by climate change, to look at that in the context of the ability of the health system to cope with those challenges in the present. And that's within the health system, but also health determining systems. So, for example, the water and sanitation system or food and agriculture systems and so on. Then to look at the way in which those health risks are likely to evolve in the future under climate change, then to consider what are the options for actions to be taken to respond to these in order to protect people's health, and then finally to bring that all together. So these are the overall steps in vulnerability and adaptation assessment. And then if we think about where we may want to use quantitative assessment, they may be relevant to some extent throughout the process, but we think they're particularly relevant in the steps of looking at the current burden of health challenges. So it's important to know, how many people are already dying of heat stress, or how many cases of malaria you may already have, what kind of a problem you may already have with food security. But we think they're particularly relevant in what we're describing as step 4, which is in looking forward to the way in which climate change may affect health in the future. So that's where we think quantitative assessment, analysis and assessment may be most relevant within the overall process. And I'll just take a couple of minutes just to give you a couple of examples of that, because there are different levels of evidence or different kinds of quantitative evidence which are relevant for this assessment. The first is to look at the way in which the hazard may evolve with climate change. So this is an example of work that we've been doing over the past 10 years or so with many countries around the world to develop climate and health country profiles, which looks at the expected change in hazards from, for example, the numbers of days which would be currently be considered to be hot days, heat stress days, the way that may evolve under different scenarios of climate change, and other kinds of hazards which we expect to challenge health, such as changes in extreme rainfall. And even just by looking at the hazard, we can start to get a picture of things that we may be quite certain about, like increased exposure to heat stress, versus others that we may have less certainty around, but which may also pose us challenges, such as changes in extreme rainfall. So we can already say, well, we're pretty certain we really know we need to prepare for increase in heat stress, and we can't discount the possibility that we also need to may need to respond to changes in extreme rainfall. So that's one kind of quantitative assessment. Moving on from that, in addition to just looking at the hazard, we may also combine that with information on other aspects of vulnerability to the stress. And this is work that we did quite a long time ago, more than a decade ago, in collaboration with the World Meteorological Organization. It's in the Climate and Health Atlas that we published at that time, which looked at the projections for changes in heat stress. And if you look on the right-hand side of this figure, these little inset graphs, the box and whisker plots, look at what is expected to happen to what would currently be considered a 1 in 20 year event in terms of extreme heat stress, out into the future, out into 2050 under different climate change scenarios. And what we can see just from the climate hazard is that in different parts of the Americas, in this case, using the Americas because this is the afternoon session for us, I assume more people are joining from the Americas, but we can do this for around the world. We can point out that in different parts of the Americas, what would previously be considered a 1 in 20 year heat stress event, by the 50s could be a 1 in 2 year event or a 1 in 4 year event, depending on the climate scenario. So you can see that there's already an increase in the frequency of maybe 10 times by the middle of the next century. So that's already a really big increase just in the hazard. But then if we look at some of the underlying vulnerabilities, we can also have a reasonable idea of what will happen to the numbers of people who are particularly vulnerable to heat stress. So we know that older populations, particularly those living in cities, where we also have an urban heat island effect, cities generally being hotter than the surrounding countryside, we are expecting to have very large increases in the numbers of old people in general, and the numbers of people living in cities in general. If you combine those, you can see for different countries within the Americas, we're expecting the numbers of highly vulnerable people to also go up by a factor of 2 or even up to a factor of 7 or 8 in different countries in the Americas, even more in some countries in Africa. You start multiplying those together and you can see that you're starting to get potentially orders of magnitude changes in the numbers of people who are highly vulnerable to heat stress and exposed to what would currently be considered a heat stress event. And on the left-hand side of the graph, you can see those changes in the highly vulnerable populations for different regions in the world. So this is a slightly more advanced kind of quantitative analysis where we're combining information on the hazard with also information on the underlying vulnerability to highlight what we're pretty sure is going to be a really significant increase in challenge of older people in particular in cities exposed to heat stress. And then just to take one more level of example, this is work that, in fact, we first started to work on in about the year 2000, where we started to estimate the global burden of disease from climate change, then updated that in 2014 to do future projections at the global level, where we were able to combine information on emissions, different scenarios of emissions of greenhouse gases, combining that also with scenarios of whether we assume that development proceeds at a fast and equitable pace, so that hopefully countries become richer and therefore better able to protect their populations, and comparing that to a situation in which if the climate had stayed the same, and if we had had a normal level of population growth and economic development, but effectively without climate change. So, as I hope you can see, we're combining projections of changes in the hazard with changes in vulnerability, and also taking into account development and the underlying burden of disease. And we were able to come up with approximate estimates of some of the health impacts of climate change in terms of undernutrition, diarrheal disease, malaria, heat, and so on in different areas of the world. So these are the same kinds of techniques that we can apply within vulnerability and adaptation assessments at the global level, at the regional level, or potentially at the national level. The final thing I wanted to say before handing back to Amy and to the next presenter is that we do think that quantitative assessment is really important. It's a really important tool to get an idea of roughly how big problems are compared to other problems. But it's also important to take into account that quantitative assessments are not the only kinds of information at our disposal. In some cases, we may not have the data or the understanding of relationships to build a useful quantitative model. In this case, it's important to not think we can't say anything about the problem. In those cases, it's also important to use qualitative methods. So, for example, qualitative scenarios to explore the possibilities of what may happen if we have, for example, severe extended droughts in different parts of the world, or if what is likely to happen if the glaciers in the Andes disappear. We don't have good quantitative models for that, but it's unlikely to be very good for health. So in those cases, we may want to use qualitative models to look at the potential health impacts of those scenarios, or to use expert judgment to consider what measures what may happen and what measures we may need to take. So just before handing back, just to sum up, we have good techniques. We have quite a lot of experience now in using quantitative assessment within vulnerability and adaptation assessments at different levels. We think that they're extremely useful, but we also need to take into account that they're just one of the assessment tools at our disposal. And with that, I'll hand back to Amy and look forward to the rest of the webinar. Thank you.
Thanks so much, Diarmid. That was a really useful overview and background on the use of quantitative methods for climate change and health V&A, and of course also touching on other methods available, qualitative methods. With that, I'm really pleased to hand over to Dr. Adugna, who will be providing a little bit more detail about the use of quantitative methods in a V&A and sharing some experiences also from Ethiopia. Thanks so much, Adugna.
Thank you very much, Amy. Good morning, good evening, good afternoon. I'm very much delighted to have the opportunity experiences from Ethiopia. Also, I would like to acknowledge the investment of WHO in capacitating countries. Before 10 years, I joined WHO as a panelist in 2014 at Geneva. And at that time, climate and health issue was at its infancy. I think now we are in a better position. There is a lot of capacity building and a lot of things are going on. So I'm the product of all those efforts. So having said that, as already introduced, I'm presenting on this topic, quantitative approach for vulnerability and adaptation assessment, sensitivity analysis and projecting future health risks of climate change. This is already mentioned. The area I would like to tackle in this presentation is step 2, where vulnerability assessment is conducted and the input for conducting the assessment, and step 4 of those 6 steps for conducting the assessment, future risk assessment. I'm very much delighted a good presentation and overview is given on those areas. Quickly moving to defining what sensitivity means. Sensitivity is the degree to which climate determines the occurrence and the spatial distribution of health outcomes. The health outcomes are not evenly distributed. There is a variability from time to time and from place to place. So sensitivity is a tool that is informing us how climate is affecting those factors. Having said that, sensitivity analysis has roughly, we have the first one is to identify important factors, like by analyzing sensitivity, we can pinpoint which input exerts the most influence on the model's outputs, and we identify those variables, and it helps us prioritize our resources and put more emphasis on those critical factors. And the second objective that sensitivity analysis will help us is understanding the model behavior. Sensitivity analysis provides insights into how changes in specific variables affect the overall behavior of a model or system. That means it helps us reveal relationship and the dependencies that might not be apparent otherwise. So the last and the most important part of the sensitivity analysis objective is enhancing decision making. We know our resources are limited and we have to prioritize our health plan or resource allocation and anything that we infuse into the health system. So the evidence generated from sensitivity analysis is helping us to make the informed decision. So in this regard, sensitivity analysis is a powerful tool for exploring and quantifying the relationship as already mentioned in the previous overview, quantitative, this analysis is part of that exercise. The other point before leaving this slide is the measurement of sensitivity analysis involved with quantifying and assessing the impact of changes in the system. So what are the considerations for sensitivity analysis? The first one is, do we have data? Is it reliable? How is the cost, the spatial distribution, and temporal resolution? So at what level of administrative unit are we going to conduct the analysis? From the morning presentation, my colleague joined me in presenting the Mozambique experience, in which they have used district level. In the Ethiopian setting, we have used another level, which is subnational. So we can have different spatial and temporal resolution to conduct this analysis. That means the data that we are using for this purpose. The other thing is, what is the capacity? We compare. Can quantitative methods be used? Are there other resources available? Is expert consultation needed to plan the analysis? So sometimes the Ministry of Health might have a certain expertise, but the expertise related to this quantitative analysis may be in the academia and research institute. So there is a need to pull expertise from various institutions. So at a minimum, analysis of the relationship between health data and average of coarse weather variables like temperature, precipitation, relative humidity, and extreme weather events and patterns can be explored. So what are variables to be considered? Data on seasonal and trends, key climate hazards, map of weather and climate and impacts such as floods, droughts, hurricane, sea level rise, all those things. It depends on the area that we are handling. Where to find data? We have to identify the country level data, which data can be found where, whether we find at national level, regional level, we have to identify source of data, whether we can find it from partners like NGOs, UN agencies, so on and so forth. Maybe this is one of the things that we have to understand along our way, the concept that we have to understand in sensitivity analysis, what is model, input, output, all those technical jargons should be clear to the people who are joining the sensitivity analysis. So this is one of the typical examples I found very important for people to capture the input, output, and the model's response. This is one of the things we can consider. I don't want to go to the detail because this is something that we are, and people could read more from some findings at country level or regional level. Before moving to other section of this presentation, I would like to focus on 3 questions that sensitivity analysis is expected to give answer. The first one is, what input factors cause the largest variation in the output? If you take malaria as an example, malaria is one of the things that is related to environmental situation. So if you take temperature, elevation, and other land use, land cover, which one of the factors are playing largest role, which are playing a crucial role? The second question that sensitivity analysis is going to give us response is there any factor whose variability has a negligible effect on the outputs? So if those factors are there, the sensitivity analysis is informing us and we'll take action in that regard. Are there interactions that amplify or dampen the variability induced by individual factors? So These are types of sensitivity analysis. I don't want to go to the details. This is something the participant could find detailed information, but I would like to give highlight about the types of SA. The first one is quantitative and qualitative sensitive analysis, as already mentioned, local and general sensitivity analysis. All those have their scope of relevance, purposes or settings of sensitivity analysis, one at a time and all at a time sensitivity analysis. So these are maybe taking this one of the types of sensitivity analysis as a case, for example, purposes or settings. This is going to help us to rank or factor prioritization. It aims at generating the ranking of the input factor. Screening aims to identifying the input factors. Mapping aims to determine the variable, how it is behaving in the different variables we have used. So there are also other sensitivity analysis settings like sensitivity analysis, SA and the model calibration. SA is almost all it is about model calibration. That means it is about improving our model by trying to screen which variables are having a larger contribution in the model. SA and the model diagnostic evaluation, SA dominant control analysis, and the robust decision making. All those are very important. That will reach by reading more articles and some documents in this regard. Before winding up this section, I would like to bring to the attention of the audience about the examples for visualization. The first one is visualize input or output. As you can see from the top upper panel, the left and the right, they are scatter plots, and they are showing us about uncertainty of scatter point on the left side, in which we don't see any, the y-axis and the x-axis, they don't have any anything that is creating a pattern. But in the other case, on the right side, we can see the panel that is showing the x-axis and the y-axis. They have the patterns in which this is showing the high sensitivity, and this is useful for screening and ranking. The second one is visualize input or output samples, in which we use colored scatter plot to take to consider as example. This is as you can see at the right, the panel at the right side is showing a sort of pattern in which we can see the red, the yellow, the water blue, and deep blue, in which there is a part, the second panel at the right side. Maybe moving to the regression analysis, we can also use this one for visualization, and we can see for screening. Quickly moving to the case study from Ethiopia. This is something done some years back, but we consider it is still important. The major objective of this assessment was to conduct, to do the assessment at population level and see the health, how the health outcomes are affected by climate change, and then to develop appropriate health adaptation strategies. We had about 5 to 6 specific objectives, but I considered for this presentation 2 of them. The first specific objective is to define level and distribution and determine the association of some health outcomes with the climate change. So These are important variables that we consider. These are the factors that we have used. As you are already familiar, vulnerability has 3 components.
Adugna, are you still there? Looks like Adugna might have dropped off. Maybe in the meantime, we can move to the next presentation and hopefully he'll rejoin us to finish off his presentation. So in that case, I would like to invite Professor Genito Maure from the Eduardo Mondlane University in Mozambique. Genito, if you would like to go ahead.
Oh, I hope you can see me and you can hear me.
We can now, yes.
Okay. So hi everyone, while I'm still loading the presentation. My name is Genito Maure, and thank you once again the WHO for inviting me to. I don't know, can you see the slideshow?
We can see it, but it's not in presentation mode yet.
Okay, don't know what's okay. What about now?
Yes, perfect.
Okay, thank you very much. So, boa tarde, good afternoon, and bonjour a tous. Obrigado, mais uma vez. My name is Genito Maure from the Eduardo Mondlane University in Maputo, Mozambique. I am a member of the technical working group Climate and Health here in Mozambique, and I've been actually coordinating the team that undertook the vulnerability and adaptation assessment of the health sector. My colleague from Ethiopia has presented a large part of at least of the methodology. So I will just build on the slides that he presented and try to move on so that I can save some time for him when he comes back to resume his presentation. So most of you are already aware of the location of Mozambique. It's on the southwestern region of the Indian Ocean, a region which is very prone to tropical cyclones emanating from the eastern part of it. We have some cases where a cyclone came all the way from Western Australia and hit Mozambique very recently. So we are also located in a region which is located downriver of 9 of the major basins in southern Africa. So that means if we are not suffering from tropical cyclones, we are also suffering. We are suffering from droughts or even flooding due to rainfall that falls beyond our borders. So that makes the burden of disease mostly dominated by climate-sensitive diseases like malaria and acute diarrhea, including cholera. Climate projections for the country have indicated that we are going to experience increases in temperature. We are going to face delays on the onset of precipitation, especially in a region where agriculture is mostly subsistence agriculture and it's rain-fed. So we are also having an increase. We are already noticing that there is the frequency and intensity of extreme weather events is going to bring additional burden and pressure to the systems. We have also adhered to different regional and international agreement. One of them has implied a commitment to produce what we call the health adaptation plan to climate. But we needed a means, a methodology to generate adaptation plan and leverage the momentum on the generation of the production of adaptation plans, sectoral adaptation plans within the country. So the objective of the work that I'm presenting is that was basically to assess the vulnerability adaptation needs to serve as a scientific basis for the development of the health adaptation plan, which we committed to produce for the country. So specifically, we wanted to develop a sustainable methodology which would help us to assess and monitor, especially monitor, because we wanted to see how those dynamic variables would affect the health sector through what we call the health vulnerability index. Also, specifically, we wanted to identify which regions within the country were the most vulnerable, and therefore that would therefore allow us to propose some specific recommendations, site-specific recommendation to strengthen the health system preparedness, and also identify some research needs and information gaps. So as a methodology, I would briefly go through this because the previous speaker has already started talking about this. What we did was to use the Health Vulnerability Index, HVI, for each district of the country. We have 162 districts. This was the first sectoral vulnerability assessment that was undertaken to such a detail. Here, the vulnerability was defined according to the variables or the components my colleague just mentioned, which is an exposure, sensitivity, and adaptive capacity. These three components were linked through this formula. I hope you can see it. HVI is the difference between the difference between exposure and adaptive capacity multiplied by sensitivity. This is the very same table as my colleague showed here. For our case, has components of exposure. We used changes in temperature, precipitation, relative humidity, and we also looked at the occurrence of droughts, floods, and cyclones. For sensitivity, we look at the components like ecosystem or geographical risks. We looked at demographics, including vulnerable population, also proportion of vulnerable groups due to health conditions. So for each of these components, we had specific indicators. For example, for exposure, we looked at changes in temperature, precipitation, and humidity between 1979 to 2016. And for demographics, we looked at specific groups as well, population density, but we also look at the under 5 children, under 15, above 15, the women in total population, and elderly. And we are now thinking of including other groups related to the internally displaced, other vulnerable groups because of the internally displaced population as well. For the adaptive capacity, we look at financial resources. So the details are all listed on this table. We look at the access of health services and the health human resources, water and sanitation, and other elements such as social determinants of health. So you can imagine the sources of information are very, 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 very dispersed, and it needs a lot of effort to get the data. So as you can imagine, we had a huge table for each of the districts with all these indicators represented in columns. We I've put all these variables. We, of course, because of the different scales of the variables, we had to normalize them. Normalizing means, for those who are not aware of the expression or of the word, means putting the value between the same population. So as results, I'm presenting here the three maps of the three being the southern region here. Here, if you look at the color, you can just look at the shade of red. The shade of red, the darker the shade of red, the higher the exposure. And here, the higher the sensitivity, and here the lower the adaptive capacity, which means the capacity to react in case of such hazard. So in overall, I will just go and try to quickly explain this map. If you look at the shade, you can see that the majority of the country is largely affected. I mean, has a low adaptive capacity, being 113 districts, which means around 84% of the territory and around 65% of the population have a high to very high or a low to very low adaptive capacity. We also notice that there is an equality between urban and rural areas. And the indicator, remember, we have columns with each of these indicators put in a numerical value. The indicator that has the biggest influence on the adaptive capacity was the WASH, especially the access to health service components, the WASH components in health. So if we go back, we have the formula which links exposure minus adaptive capacity divided multiplied by sensitivity. This minus, sorry, this adaptive capacity multiplied by sensitivity. This map result in this one, which means we have a very, I mean, in general, high to very high health vulnerability index. This represents around 32% of the territory and around 24% of the population. With 8 districts, they're the ones that are darker here on the map, are the ones which have very high health vulnerability index. In the map, we found that 80%, 75% of the least vulnerable district, which means those that are least vulnerable in terms of climate, at least the indicators, are urban. So yeah, I would just go quickly. We have already talked about exposure, the sensitivity. What I'd like to mention is the adaptive capacity, with the details I gave, is that, as I was saying, is that the WASH within the health service has the worst performance. And these components were highly sensitive to cyclones from our calculation. When we calculated sensitivity, this is the sector that gets the most affected by cyclones, specifically WASH. And in the context of our country, WASH is managed by a different entity. So has concluding remarks, but I'm not finished yet. I'll be quickly moving to some additional slides that I would like to share with you. Is that the HVI, the Health Vulnerability Index, is mimicking the behavior of adaptive capacity. And if we have a table that gives us the variability of the adaptive capacity, that means we can target specific intervention measures to specific places and try to change the adaptive capacity of that place, and therefore increasing or reducing the vulnerability, the health vulnerability index, or the vulnerability of that specific district. We have therefore established a baseline, scientific baseline that can be used to develop the national adaptation plan, which is something that is ongoing now. So I think it's also important to mention the limitation of these methodologies, specifically for the case of Mozambique. The limitations, as my colleague was saying, are mostly related to the existence. We have to take this into consideration: the existence, the availability, and the quality of data. In countries like ours, for the case of Mozambique, we have a very poor coverage of the national meteorological network. The stations are very limited. We have discontinuities in the time series, which is bad if we want to look at how the variability of climate is affecting the health sector, specifically for climate-sensitive diseases. If we have discontinuities, that becomes very difficult. We also have a lack of systematic recording or specific reports of extreme events, especially for the case of Idai. When we were affected by Idai, the station in Beira Airport in Mozambique was destroyed by the Idai itself, while it was still measuring, for example, precipitation amount. We have had elements related, for example, to wash data. Wash data, although it's very important to calculate the health vulnerability.
Seems like we're having some...
Integrate the district health information system and the previous system that was being used by the Ministry of Health. I will not go into recommendations because I think recommendations will be site-specific and will be a function of the conclusions or the limitations. But I wanted to share with you what we are doing now. We are using this is an article in preparation. It's already been presented in its preliminary format. It's an artificial intelligence based tool to predict outbreaks of diseases. We are working in parallel. There is this initiative at the Ministry of Health that is looking at, is being supported by the WHO, is using EWARS. EWARS is the early warning system that is being established at the surveillance at Mozambican Health Observatory. But at the university, in collaboration with the Institute of Health, we are training an algorithm to mimic the observed outbreak patterns. So we have chosen here a province that is very much prone to malaria outbreaks, and what we have noticed so far is that the forcings, the variables, the variables that are I would call it the predictors to outbreaks, they are site specific. So this means if we know which predictor, for example, here we have mean temperature, relative humidity, precipitation, population, and minimum temperature, and so on and so forth. So we have which one is the most relevant to predict, outbreak. So that means if the other indicators are not changing, or if we know how the other indicators are changing, we can use this, and using the scenarios of climate change, we can put them together and use the scenarios of population growth, for example, for specific locations, and somehow try to assess risk. So these are just a few of the results that we got. And here is some of the important results that the EWARS system, the WHO supported system, is generating. Is using positive predictive values, sensitivity, false alarm rate, and accuracy. And you can see in general, we are very close to 1. This means we are very close to the results. The results that would be that would grant us some confidence in the work that we are doing. So we're doing this because we also want to compare with what EWARS, the system that is mentioned, is generating, just for a matter of intercomparability, or a matter of generate something that has got a reference. So yeah, this is another additional work that we're doing. We have already done some heat waves. I think Diarmid has mentioned this at the beginning. We have something that is coming on the future of heat waves. So we also want to take these variables and include them instead of only having droughts, floods, and we want to include heat waves and so on, so that we can see how the outcome. We have got some results that we are already incorporating, some generated by some of my colleagues at the university, which is the future climate of Mozambique based on different scenarios. So this is also going to be part of what we are doing. So finally, there is a publication, it's freely available, which is on the assessment of vulnerability of the health sector in Mozambique. This is a comprehensive study. We hope you can look for it on the internet and use it. Feel free to contact us. I'm the second on this list of the authors. So yeah, that would be it for now. Thank you. Over to you, Amy.
Thanks so much, Genito, for sharing all that really extensive work that you and your team are doing in Mozambique, and also some of those novel approaches related to using AI. It's incredibly interesting. And thank you for your adaptability and flexibility to take over when Adugna dropped off. I think we have Adugna back now. So if you're there, Adugna, would you be able to start from where you left off and finish off your presentation with the experiences in Ethiopia? Are you there, Adugna? Maybe we're still having some technical issues. So I think in that case, we will move on to the next presentation. And I'm really pleased to introduce Dr. Peter Berry from Climate Change and Health Office in Health Canada. Thank you, Peter.
Great, thanks. I'm just going to share my screen and then we'll get started. Can you see this okay? Not
yet. Yes, now.
Okay, that's really great. Well, thanks so much to the World Health Organization for the opportunity to join this meeting to present on the Canadian experience and the quantitative approaches with respect to climate change and health assessments. Certainly health risks from climate change are increasing very quickly, and so we really need comprehensive and robust information. And so this is a really timely discussion, and it's been really great to see and learn from the excellent presentations from the other panelists. So I'm really excited to be here today. Bring a bit of a different perspective in that I'm the lead of our next climate change and health assessment. I'll talk about the previous one and some of our experiences with using quantitative methods. But my expertise is really around health adaptation, building climate resilient health systems. I've had the great pleasure as the editor for the past few assessments to work with a number of experts that actually undertake a number of the analyses that have already been talked to today, and sort of thinking about how best to integrate these into assessments has been really interesting, and to communicate the results, and I'll speak to that a little bit more. But in the time that I have, I'll just very briefly just talk a little bit about the health risk to Canadians from climate change. Of course, some of the quantitative methods to understand climate change risks and adaptation options, from the Canadian perspective again, and also just a few examples of our experience with quantitative approaches for undertaking climate change and health assessments. And so many of you will be aware that Canada is a very vast country. It's a very large geography. And so people in Canada experience really a range of impacts from climate change that impact health. So, had some major wildfire disasters recently, and extreme heat is a very significant issue for many countries across Canada. In 2021, in the province of BC, We had 619 deaths in just over 5 days, and so very severe impacts that we can have from these events. Certainly, infectious diseases are a significant concern. We're seeing Lyme disease move north into Canada. And certainly our First Nations, Inuit, and Métis peoples are experiencing a wide range of health impacts from climate change. For example, impacts on food insecurity because of some of the impacts, impacts on caribou and other foodstuffs. And so we have a very wide range of health concerns that we need to address through climate change and health assessments with a variety of methods, including quantitative methods. And so, as I mentioned, we did release our recent, in 2022, actually it's been a few years now, our National Climate Change and Health Assessment. And over the years, Health Canada has worked with many partners at local to national levels, researchers, health decision makers, to undertake these assessments, and to use both quantitative and qualitative methods to really get the most robust results that we can to inform that decision making. And so this figure provides a bit of a snapshot of some of the results from our recent assessment. I've already mentioned some of the examples of health risks that are of concern in Canada, but also the importance of a number of vulnerability factors that really mediate health outcomes that really need to be taken into account in some of these types of analysis. And I should also mention that the application of Indigenous knowledge just to understand risks, but also opportunities for health adaptation is really an integral part of these assessments as well. And so in Canada, we're really building the capacity to undertake the climate change and health assessments from local to national levels, and use a wide range of scientific methods, such as quantitative analysis. And so Health Canada, supported through financial support, but also technical advice, a number of health authorities across Canada through our Health Adapt initiative, to undertake their own assessments, but also start developing health adaptation plans based on the information from these assessments. What's really interesting about that initiative is there was a community of practice that developed around the initiative, and there was a lot of discussion, a lot of exchange and learnings about some of the challenges, and I'll speak to this, in terms of undertaking some of these methods, quantitative methods, when you're doing a climate change and health assessment. So that was a really useful forum to exchange information and to be able to learn from each other as they're going through the different stages of doing an assessment that have already been highlighted by Diarmid and other speakers. And so, the vulnerability and adaptation assessment cycle is really sort of the anchor of a number of the stages of health adaptation that we go through in terms of undertaking efforts to protect health. And so this is from things like building awareness that climate change is an important health issue, to groundwork adaptation phase in terms of actually conducting research, doing surveillance and monitoring, but also implementing concrete adaptation measures, for example, emergency preparedness and management measures, and then even undertaking that monitoring of whether or not we're making progress towards building climate resilient health systems and ultimately protecting health. And so, quantitative studies are really, really important in terms of providing the information for all of these different types of activities. And the WHO has got some really excellent guidance for undertaking these initiatives and or these assessments. And so this is really, really helpful. It's been very, very helpful to health authorities in Canada, including Health Canada. And so, assessments really require close collaboration among researchers and experts from a wide range of disciplines, applying many tools and methods. So, a number of examples here, but just examples in terms of quantitative methods, and a number of these have been discussed in a bit more detail. But environmental epidemiology, short and long time series studies, ecological studies, the use of geographic information systems with some of this data really quite helpful to be able to visualize as a decision maker some of these vulnerability issues that are in our communities in terms of health, and to be able to target some adaptation measures that are needed. Projecting health impacts into the future, the use of climate and health modeling. Things like biological models of infectious disease transmission, but also cost-benefit analysis and even the use of surveys are really important. And these in assessments are used in conjunction with a number of qualitative methods, of course, interviews, single event case studies, focus groups, participatory workshops, expert consultations, narrative inquiry, and even visual and art-based methods. And that's actually been really interesting in the Canadian context in terms of the use of some of these visual and art-based methods, things like art competitions among youth where the results can be used in assessments, and a lot of interest in that, in communicating some of the results, but even better understanding some of the risks and some of the populations that are really affected. And so, for the rest of my presentation, I'll just focus on a specific example in terms of a quantitative method, really modeling the health risk posed by climate change. And in Canada, they really fulfill a diverse number of purposes that help Canadians prepare for the rapidly warming climate. So, to understand the exposure response relationships, such as the health effects of heat and high temperatures, to look into the future again, to understand health implications of different climate projections, including stresses to health systems. There's much more interest, I think, and urgency with looking at health systems and how prepared they are for climate change, and thinking about how can we use some of these methods to really get a better understanding of the resilience of health systems, but also enhance the effectiveness of early warning systems. We can use this type of information to more severe events that are expected with climate change. And so we're seeing, combined climate change events, extreme heat and drought and these types of things that we really need to ramp up and scale up our adaptation efforts. And so we need this kind of information to be able to do that, but also to assess health costs and benefits related to climate change, climate adaptation policies, and climate change mitigation strategies as well. And that's really quite important. But I think this has been mentioned a bit in the other presentations. There are some key challenges and gaps for climate change and health modeling that have been experienced in Canada. Sometimes there's insufficient data over long enough time periods. There's certainly the need to coordinate with other partners in the health sector in Canada, the provinces and territories that hold some of the long-term health data sets. So that's really quite important, obviously, to get the best information. Sometimes there's a lack of robust understanding of some non-linear processes that link climate factors to health outcomes in terms of developing useful and the best models. And these health models are needed for each health outcome of concern. Many I've already mentioned, but even some of these areas of new concern that certainly we're seeing in Canada, I know internationally, climate change impacts on mental health, for example. This is needed to project an overall impacts on human health and health system moving forward. And of course, sufficient financial resources, expertise, and time are needed for this work. This work can take a fair amount of time, and one needs to factor that in when you're undertaking an assessment. And so just, to kind of bring my presentation to a bit of a close, just some specific examples from colleagues that have led this work that has been included in the recent assessment. I did forget to actually provide a reference list, but I will do that in the presentation that I provide that's posted, so that you can go into some of these studies and get more specific information. But one of the studies that a colleague in our office, Dr. Chris Hepburn, led was the CAN-TEMP, the Canadian Temperature-Related Excess Mortality Projections project. It actually used a two-part time series analysis to really look at what do we expect in terms of mortality in the future with the changing temperatures, and certainly identified that we do expect more impacts in Canada, particularly for older populations. And so that came out of this particular analysis as being very important. And so, you know, something that can be and is being used to plan things like heat alert and response systems moving forward. But a colleague in the Public Health Agency of Canada a number of years ago now, Dr. Nick Ogden, also developed risk maps to examine the possible spread of the tick, or one of the ticks in Canada that causes Lyme disease. And I mentioned that before as being really important. And so, you know, using a simple risk algorithm to develop these risk maps based on a fair amount of information in terms of how the tick it sort of changes with respect to a warmer climate. And what's really interesting is in the previous assessments, the results of these projections and these maps has actually been validated. And so we are seeing really an exponential rise in Canada from climate change in terms of Lyme disease. And maybe I know time is a bit tight, so just one other quick example. Another project led by colleagues in the AIR program at Health Canada in their chapter in the assessment looked at the estimated the health benefits of greenhouse gas emission reductions. And it really took the results from climate modeling, which fed into models of air quality impacts, and then fed into modeling the health impacts from that, and some of the valuation around that. And it really found that by employing mitigation strategies in line with keeping emissions in Canada under these strategies under the RCP 6.0, sort of a moderate emissions scenario, Canada could avoid around 5,200 premature deaths annually in 2050. So really significant health benefits of doing that. And again, so this is very useful information for informing decision making moving forward. And so maybe just to close, just a few concluding thoughts. It's really important that scaling up health adaptation actions requires robust science and evidence, and we do need to scale up health adaptation actions quickly. Quantitative methods used in climate change and health assessments, they really provide needed information to decision makers, so really, really very important. But special efforts, I think, are needed to focus on communicating the results of climate change and health assessments in a meaningful, tailored, and timely manner. And I think sometimes this can be specifically the case for results from quantitative assessments and studies. Sometimes it's not clear what these numbers mean, and we need to take the time to communicate this, I think, in a very clear way moving forward. And always thinking about how to do that. But health authorities can build their capacity to increase the knowledge of health risks and adaptation options, and doing this through these different methods that have been discussed today. So thank you very much.
Thank you so much, Peter, for sharing those experiences from Canada, who has quite a strong history and experience in conducting V&As. There's a lot to learn from this experience. We are going to try one more time with Adugna, so I hope we'll be able to hear his presentation from Ethiopia. So Adugna, if you're able to speak, I know there were some issues with the unmuting before. I can see you sharing your screen. I would ask if Christina is able to see if she can unmute Adugna. I think while we're waiting to see if Adugna can rejoin, I can see he's just left. We're going to have some time in any case at the end for some discussion. So we could start with some discussion. If you have any questions for our presenters today, you can see there's been a little bit of discussion already in the chat. I don't know if anyone who has written in the chat would like to ask their question. I can see some of them have already been answered in the chat, but maybe you would like to elaborate. If you would like to ask a question, just raise your hand and then let us know which speaker you would like to direct your question to. I don't see any hands at the moment. Okay, yes, we've got one. Vicky, you would like to, you can even put on your video if you wish.
Okay. Please, can you hear me?
Yes, we can.
Okay, so my name is Victoria Kandi from AIMS. AIMS is a research and innovation center at Rwanda, and we are basically coming from the African Institute for Mathematical Science. So my question is basically unrelated to our presenter from Mozambique. And I just wanted to thank you for your good presentation, and it was very detailed. The methodology was very comprehensive. But my question is basically you mentioned that there is a challenge in getting data. So I just wanted to know basically, because to be able to do the assessment that you did, I think you got some of the data. So how have you managed to get those data from the local institution? Because basically this is an issue that we all are facing in Africa. So I just wanted to know how you manage to get even though they are not, you think that they are not high quality, but at least you got some data. So how have you managed to get to such kind of data? Thank you very much.
May I go on, Amy?
Yes, please. Thanks, Genito.
Yeah, thank you, Vicky. Yeah, that's an interesting question. Yes, I would just start by bringing the example of demographics. At the time that we conducted this, the study, the country was updating. Mozambique was updating its census. We have a 10-year cycle of census. So there was a huge debate on television because some projections of some previous projections of the population were not met at the time that the census was conducted. So we were in a situation that we were not very sure of which data to use. So we went back to the projections because those were already approved. And we use that. Of course, there are some limitations because at the end, when the new census was approved by the government, we had already finalized our work. But this is one type of data, of problems with data. Another type of problem with data is that we tend to work in silos. So my data is my data, and the format that I collect the data is not the same that you need the data to use. So we have to sit down and use some interpolation methodologies, discuss with the people, show them the importance of the data to the country, not only to. We're talking about the health sector. The health sector is like everybody in the country, so it should be important for everyone. So you need to negotiate this. You need to have the buy-in by the policymaker. The leadership of the Minister of Health is very important. That's where you should start from if you want to conduct such kind of processes, because it needs to be the one that the sector itself showing the importance of the work that is being done. So just two examples. I have several more examples, but yeah. And we also met services. We had to use interpolation in most of the cases because of the discontinuities of the available observations in the country. Use Copernicus, ECMWF, and so on. Yeah.
Thank you very much for that.
Thanks, Genito. I can see that George Batona also has his hand up. Would you like to go ahead? George?
Oui, bonjour, George.
Bonjour. Oui.
Okay. Merci, Amy. Alors, I will speak in French. C'est possible? OK, merci.
Oui, ça va.
Alors, donc, je suis Dr Georges Batona. J'appelle du Congo, Bureau de la représentation de l'OMS au Congo. Alors, d'abord, je voulais remercier. Ma question s'adresse à Peter, mais aussi à Dr Genito, que j'ai rencontré, n'est-ce pas, dernièrement à Madrid. Alors, je suis très content de vos présentations qui ont apporté beaucoup d'informations, d'éclairage sur l'utilisation des méthodes quantitatives dans le cadre de l'évaluation de la vulnérabilité et de l'adaptation. Et nous, on est en train de préparer justement, on est dans le processus de mener l'évaluation de la vulnérabilité et de l'adaptation et nous aurons un atelier très bientôt au courant de ce mois et nous allons élaborer une feuille de route. Et la question que je voudrais poser en lien, parce qu'on doit constituer une équipe donc, qui va conduire l'évaluation. Alors, pour utiliser ces méthodes, c'est sûr qu'on aura besoin de méthodes mixtes, c'est quantitatives et qualitatives, compte tenu de la nécessité certainement d'avoir des données qui doivent se compléter, mais surtout des limites que nous avons observées, c'est-à-dire, par exemple, la disponibilité de données, surtout dans le contexte africain, où c'est souvent les données ne sont pas disponibles, ou ils sont parcellaires. Alors, donc, pour venir à la question, comment vous avez procédé, docteur Genito, pour pallier un peu aux difficultés, n'est-ce pas, liées à l'insuffisance ou la faiblesse des données, ou tout simplement l'inexistence des données, pour pouvoir faire des projections? Ça, c'est un. Deux, pour constituer l'équipe, n'est-ce pas, il faut qu'il y ait de l'expertise, surtout sur les aspects épidémiologiques. Et bon, dans notre contexte ici au Congo, il y a des chercheurs universitaires, c'est vrai, qui ont peut-être ces expériences, mais ce n'est pas toujours évident d'avoir des compétences pour pouvoir mener donc, des analyses de régression de sensibilité. Et donc, ça nous amène à vraiment, peut-être que ça peut déjà être une limitation, avec l'expertise technique des compétences pour faire ces analyses-là, en dehors de l'insuffisance de données. Et enfin, le dernier point, Dr Peter, j'ai vu le guide de travail du Canada pour l'évaluation, donc pour conduire les différentes évaluations de la vulnérabilité et de l'adaptation en français, en version française. C'est très détaillé, c'est très intéressant. Je pense que nous allons beaucoup l'utiliser. Est-ce que vous avez, en dehors de ce guide-là, qui est en français, un autre document de travail en français lié à l'évaluation que vous avez réalisée, donc les résultats de l'évaluation de la vulnérabilité et de l'adaptation dans le contexte canadien? Ce serait très utile pour nous parce qu'on pourrait aussi s'en inspirer. Merci beaucoup. Je m'excuse d'avoir été long.
Merci, Georges. We will start with Genito. So there's questions. Sorry, I just have to try. There's questions to both George and to Genito and Peter. So Genito, did you catch that, or would you like me to summarize?
I think I catch one at least. Well, the first one seems to be more or less the same as the previous question that was presented by Vicky, right?
About the challenges and the gaps and absence of data.
Yeah, and the other one is what recommendation would be in terms of lack of expertise, I mean, to undertake this kind of work.
Exactly. Yeah.
Okay. So merci beaucoup par cette groupe de questions. I'm going to change to English now. So in terms of gaps in terms of data availability, I was explaining to the previous intervener that we have several types of data gaps. You have the situation where you have the data, or at least the data exists, but it's not accessible. Accessible because we are working in silos. You have a situation where the data exists, it's accessible, but doesn't have the it doesn't have the format that you need, or at least is required for the data to be used in the way to produce or at least to work as for the assessment that you want to conduct. And you have a third situation where you don't have the data, so you will have three different solutions for each. I mean, you have a single solution for each of the cases. Where you have the data and the data is available, just negotiate and go get the data, but you always use the leadership of the Ministry of Health. Where the data has got gaps, there are gaps in the data, then you have to find a way to fill the gaps, either by going to interpolate the data from similar circumstances, similar regions in terms of climate or agroclimate, or you can even interpolate from the global gridded data sets that exist. Of course, that requires knowledge that is somehow linked to the question that you have presented. And the third situation is, I think that the solution is either neglect the data or try to get data that from a region that is similar to fill, again, I wouldn't call it a gap, but the lack of data. So in terms of a recommendation, I would just bring the example of Mozambique. We started with a collaboration with the support of the WHO. We had sort of a training of trainers initially, where we had a professor that came from the University of Namibia. He's a biostatistician, just to give us a context of what is happening. My background is not health. I'm a climatologist. I'm a climate modeler myself. But I found myself deeply engaged in the climate and health, that I know some of the nuances already, and I can somehow advise people on what kind of expertise you would need on that. You would need a biostatistician, epidemiology, and if you don't have that in your country, you can always resort to the region. I think that can also help. There is a lot of knowledge in the region that can be shared around. So I think that's the role of being in places like a university. Our role is to share knowledge. So I believe every other university will do the same. Yeah, I hope I've responded to the questions.
Thanks so much, Genito. There was also a second part of the question that was to Peter, and just in case people didn't catch it, George was explaining that they've looked at the guides that Health Canada has developed around V&As, and particularly they've got a version in French, which was really useful for the Congo context. And they were just wondering if there's any other information that Health Canada has available in French, maybe for V&As and also for adaptation. Peter, if you're still there, yeah.
Yeah, thanks so much for the question, and it's really great to hear that that you thought the guide was useful, and so thank you for that. And I recall in your question a specific focus, I think, if I'm not mistaken, on developing adaptation options and understanding what actually one needs to do to protect health and health systems. And this is, I mean, in my experience, this has always been a difficult area in terms of some of the analysis. Sometimes because of different jurisdictional responsibilities, or because the issues are just so broad. There's so many issues and so many options. So I think in our guide we did have information on the types of the ways that you can approach that kind of analysis in terms of the criteria that one can use to go through that kind of decision making. I'm just trying to think if there are other examples from Canada that are in French that I could provide. I've been to some really excellent local or regional sort of assessment workshops where people have worked through this very thing in terms of what are the best adaptation options. They've done it with stakeholders that deal with and provide assistance to people on the ground that are suffering from some of these impacts and have considered the adaptive capacity of organizations and whatnot. So I'll try and think if there are some of these examples that might be useful for you and that are in French. The only other quick thing, because I know we're coming close to time, one of the things that we're hoping to do, and it still needs to be finalized and approved, is actually measure the climate resilience of Canada's health systems in our next assessment. Really building on some of the guidance and borrowing from the guidance that the WHO has developed to understand if we're making progress in terms of adaptation. And so I think the guidance that the WHO has developed could be quite useful in that regard, in terms of thinking about adaptation needs moving forward. And so we're going to be trying to do that, just because it's so important to understand, with impacts increasing, if we're scaling up quickly enough our adaptation efforts. Thanks.
Thanks so much, Peter. We have a few minutes left before we need to close the webinar. I can see that we have at least one more hand up, so I invite Dr. Rachel Williams to unmute.
Hi, morning everyone. It's not a question, basically a statement. I am also a biostatistician, so there's always a lack of trained biostatisticians, not only in the Caribbean, but around the world. So if anybody wishes to connect with me, I will put my information there, because I used to teach biostatistics and research methodology at the universities here. But I'm working as a consultant now, and I do work online and face-to-face. So if anybody needs my assistance, I'm here to help you.
Great, thanks so much, Rachel. Do we have any other questions before we finish up? I can see there's one in the chat. Melanie was asking Genito why the 2007 IPCC methodology was used and not the most updated one that considers risk as a variable. But Genito's answered that it was not available at the time. So I think we can probably finish up here. If you have any other questions, of course, you can be in touch. And I also wanted to thank Adugna for joining. He is out in rural Ethiopia. Unfortunately, he was not able to reconnect well enough to be able to finish his presentation. But if you are interested in hearing more about the experience of Ethiopia and some more details on quantitative methods for V&As more generally, he was able to present his full presentation this morning in this morning's webinar. So when we upload those recordings, it will be available in the recording. So thank you, Adugna, and thank you to all the presenters today. We really appreciate the time that you take to share all your work and your experiences. And then thank you to all the participants for joining, for engaging in the webinar today with all the questions in the chat and the discussion. So with that, I'll remind you that we, of course, do have some more webinars coming up in this series. If you have any other topics that you would like to cover, just let us know, and we'll take a break in August. So happy summer holidays to those of you in the Northern Hemisphere, and thank you all for joining, and see you in the next one. Goodbye.
Thank you.
Thank you.
Bye-bye.
Bye-bye.